The human body, it really is just fascinating, isn't it? Especially, when things aren't quite running smoothly.
Absolutely. It gives off these clues, sometimes really subtle ones.
Right. And if you can learn to read those clues, it just opens up a whole new way of understanding what's going on inside.
It's like deciphering a code almost.
Yeah.
Minor details can point to really big picture issues.
Exactly what we're doing today. We're taking a deep dive into one specific area where these small differences tell a big story. How to tell apart two common types of leg ulcers.
Arterial and venous ulcers.
Yeah, arterial and venous. And they might sound similar, but they come from, well, fundamentally different problems in our circulatory system.
Wholly different root causes. And our mission for you in this deep dive is pretty straightforward.
What's that?
We want you to be able to clearly spot the key features of each type. Focus on where they pop up and what they actually look like.
So you get a quick, solid understanding, cutting through some of that medical jargon, maybe.
Exactly. Get right to what you need to know to understand them.
Okay. And for this, we've pulled the key ideas from a really helpful educational video that really breaks down the basics.
Yeah, it distills it quite nicely.
So let's get started. To really get a handle on these ulcers, we first need to talk about the main problem behind each one.
Right, the core issue.
Yeah.
Because like you said, they're different. With arterial ulcers, the main problem is with the peripheral arteries.
One's going out to the limbs.
Exactly. They're just not doing a good enough job supplying the extremities. So that means the rich oxygenated blood, it can't really get down there effectively to perfuse the tissues.
Perfuse meaning like deliver the blood properly.
Yeah, deliver it down to the capillary level, provide that essential oxygen.
Okay, so if that blood flow is blocked or maybe just really slowed down, the result you see, the signs and symptoms, they're all going to be related to ischemia, that lack of blood supply.
Spot on. Ischemia. The tissues are essentially, well, starving for oxygen. It's a direct cause and effect.
Makes sense. Okay, so what about the other type? Venous ulcers, also called venous stasis ulcers, right?
Right, venous stasis ulcers. Now, here, the circulatory system faces a totally different kind of challenge.
Okay.
The issue is with the venous system itself, the veins.
The ones bringing blood back to the heart.
Yes. So either the veins themselves are damaged or maybe the little valves inside them are kind of overstretched and leaky.
Ah, the valves.
Yeah, so they can't effectively drain the blood back up towards the heart like they're supposed to.
Okay, so if that drainage system isn't working properly, what happens then?
Well, the blood just pools. It gets stagnant, usually down in the lower legs, and that leads to pretty significant swelling, edema.
So you've got one case where blood can't really get to the tissues effectively,
Arterial.
and the other where it can't really get away effectively.
Venous. Exactly. That fundamental difference is really the bedrock for understanding why they look and act so differently.
Got it. Okay, so that difference in the basic problem, that must affect where these things actually show up, right? Location. That's our first big clue.
Absolutely. Location tells you a lot. For arterial ulcers, you're typically looking at the lower extremity, like below the kneecap.
Okay.
And common spots are, say, the ends of the toes, the top of the feet, sometimes called the dorsum of the feet.
Dorsum, okay.
And a really kind of classic spot is the lateral malleolus region.
Lateral malleolus. That's the bony bit on the outside of the ankle.
That's the one, the outside ankle bone.
Okay. Outside ankle for arterial.
Right.
What about venous then? Where do they like to hang out?
Different neighborhood, as you said. They're usually on the medial parts of the lower legs, so still below the knee, but
Medial mean inside.
yes, the inside. And the most common location, this is a key differentiator, is the medial malleolus region.
Ah, so the inside of the ankle area.
Exactly. So think arterial often on the lateral, the outside ankle, and venous often on the medial, the inside ankle.
That's a really clear contrast. Lateral versus medial ankle. Is there a simple reason why it splits like that?
Well, yeah, it kind of makes sense if you think about the pressures. Arterial blood is being pushed out against gravity in resistance to the furthest points, right? Like the toes and the outer ankle where circulation might be weakest.
Okay.
Venous blood, though, is trying to get back up against gravity. It tends to pool where the pressure is highest in that faulty system, which is often lower down, around that inner ankle, the medial malleolus. It's like the lowest point in the drainage basin almost.
That explanation helps a lot, actually, understanding the why. Okay, so location is one big clue. What about what they actually look like? The appearance must be different too.
Oh, absolutely. The visual cues are maybe even more revealing. Let's start with drainage and healing tissue, what we call granulation.
Okay.
For arterial ulcers, you generally see very little drainage and very little granulation tissue.
The new healthy tissue you want to see for healing.
Right. And that makes sense because of the poor blood flow we talked about, right? If you don't have good oxygenated blood getting there.
The wound just can't heal properly or drain much.
Exactly. Now, flip that for venous ulcers.
Okay.
With venous ulcers, you usually do see drainage, sometimes quite a lot, and you'll see the granulation tissue is present
Why the difference there?
because blood flow is getting to the wound area. Remember, the problem isn't supply, it's a return. So the wound actually has the resources, the blood supply, to try and heal, which leads to more drainage in that new tissue formation.
Got it. Supply issue limits healing in arterial. Return issue doesn't stop it entirely in venous.
Okay, what about the color of the wound itself and the skin around it?
Big differences here too. Arterial ulcers, they can look pale, maybe a very light pink. Or in really bad cases, they can be necrotic.
Necrotic meaning dead tissue.
Yeah.
Black.
Yes, black, dead tissue. The wound bed itself is usually described as pale or maybe grayish, and the skin surrounding it typically looks dry, scaly, maybe kind of shiny and tight. Hair loss on the leg is also common. Dry, scaly, pale, maybe black. Okay, venous?
Venous ulcers paint a much different picture. The base of the wound is often deep pink or red.
Because of that granulation tissue you mentioned?
Exactly. That indicates active, albeit struggling, tissue,
Mm-hmm.
and the surrounding skin. Usually looks swollen, feels tight because of all that fluid pooling.
The edema.
Right. And a really common feature, very characteristic, is this brown pigmentation, like staining, of the skin around the ulcer.
Brown staining. Where does that come from?
It's called hemosiderin staining. It's basically from red blood cells leaking out of those congested veins into the tissue over time. The iron pigments leave that brownish color.
Wow. Okay, so pale, dry, possibly black for arterial versus red, swollen, and often brown stained for venous. Very different visual.
Absolutely. And then there's the shape and depth.
Oh, right.
Arterial ulcers tend to be quite deep. They often have this classic punched out look.
Punched out like someone literally took a hole punch.
Almost, yeah. Like someone pressed their thumb in hard. It gives them these really distinct, noticeable, often round edges or margins. Very defined.
Deep, round, punched out. Okay, venous ulcers.
Generally shallower. And their edges are not neat and round. They tend to be irregular, maybe more jagged or uneven in shape.
So the opposite again. Arterial, deep, precise, round. Venous, shallow, irregular edges.
You got it. It's quite a contrast across the board, isn't it? Location, drainage, color, depth, edges.
It really is, and when you lay it all out, you can really see how those distinct features, the location, the appearance, they're all direct consequences of that fundamental circulatory problem we started with.
Exactly. Understanding the why the arterial supply failure versus the venous drainage failure really helps lock in the what you actually see.
It's not just a list of random symptoms, it's like the body telling a very specific story about what's going wrong with the plumbing, basically.
That's a good way to put it.
And because we understand that story, the why, it points directly to how you might approach treatment, right? Like for venous ulcers, doesn't compression help a lot?
Oh, absolutely. Compression therapy is a cornerstone for venous ulcers. Things like an Una boot.
What's that exactly?
It's a special kind of compression bandage. It's gauze, often impregnated with zinc oxide and calamine, that hardens. It provides firm, consistent compression.
And that helps
Because
because
it physically helps squeeze that pooled blood back up the leg, aiding venous return. It provides external support for those faulty veins and reduces the swelling, which promotes healing.
so understanding the root problem, poor drainage, leads directly to a solution like compression that targets that specific issue.
Precisely. It shows how knowing the difference isn't just academic. It leads to tailored, effective care.
That makes perfect sense. Okay, so recapping quickly, we've really unpacked the key differences between arterial and venous ulcers.
Yep. Looked at their root causes, supply versus drainage.
Where you typically find them, think lateral ankle for arterial, medial for venous.
And what they look like. Pale, deep, punched out for arterial versus red, shallow, irregular, often with surrounding swelling and staining for venous.
Right. Understanding these is pretty vital for anyone wanting to grasp circulatory health a bit better.
Definitely. You now have like a mental checklist, a toolkit to quickly tell these conditions apart, which could be really useful, if you've ever heard them discussed, or just for your own knowledge about how the body works.
Or doesn't work sometimes. It really shows how the body sends out these signals, these clues, and knowing how to read them can make such a difference. So here's something to think about.
Okay.
We've seen how these two types of ulcers, both sores on the leg, point to very different underlying issues. What other subtle signs or symptoms in the body, things that might seem kind of similar on the surface, could actually be signals for entirely different root causes? And, maybe more importantly, why might understanding those distinctions be really critical?